and he also sits on a number of boards for us. But one of them, we also sit, the city negotiates its healthcare as a group to obviously get a better purchase price and try to find us the best deal we can. And they've just renegotiated the healthcare plan for 2014, and we're going self-insured 2015, Jim?
That's
So
the plan.
that's the plan. So he's going to go ahead and explain what's in place for us next year. So when you get open enrollment in October, you guys can make a educated decision on which plan you want to choose. Go ahead, Jim.
Thanks, Mark. Thanks, everybody, for coming. The board and I thought that it would be a good idea to have me come ahead of open enrollment and ahead of people getting their packets in the mail this year, just because there are some significant changes with the health plan, and we wanted to have an opportunity, first of all, to explain those so everybody can understand, and then ask any questions that you have. So if you have questions along the way, let me know. Holler them out nice and loud because we're videotaping this so it can be shown to the other part of the membership meeting tomorrow morning. What I'm going to do is I'm going to go through an overview of how the process works and how we determine our health insurance plan from year to year. Talk about what issues we faced this year as we were looking for what the plan was going to be in 2014. And then I'm going to give you a summary of what that is, and then actually go through and explain kind of why the group felt that this was the direction we needed to go. And as I said, if there are questions along the way, just let me know. And I thought that was working, but maybe it's not. Okay, the health insurance plan is really determined by the BLMC, which stands for Benefits Labor Management Committee. It's been around for about 13 years, and it's got representatives of both labor and management from the city. And we sit down and actually work together to deal with the health insurance providers, and we found that by doing that, rather than having them dictate rates on us and then watching us fight with each other, it's been a lot more productive. So it's been a very successful model that we've used for, as I said, about 13 years. Our mission, as we first started it 13 years ago, was to provide quality health care in the most cost-effective manner without bankrupting people with serious medical conditions. So basically 3 guiding principles. 1, it has to be quality health care. 2, it has to be as cost-effective as possible, and that's an increasingly difficult challenge with what's going on in health care and has been through the last decade. And 3, we need to make sure that we have a safety net for the people in the city and their dependents, so that if they do have a serious medical condition, it doesn't cause catastrophic financial difficulty for them as well. And so we use those principles whenever we look at potential changes to the plan, which we do virtually every year, because we're always looking at, what does our plan look like, what are the cost drivers for the plan, what are our people, we never get individual data, but as a group, what things are we facing? How do we compare with other employers, other public employers? But when we consider to make changes to the plan, the focus is on the value of the premium savings. So in other words, we're going to change the plan because it can save us money, versus what are the costs that are being passed on to the end users, which are obviously the employees and their dependents. We look at that cost in the aggregate, but we also look at it on an individual basis. So with that background, these were some of the realities and the issues that were facing us when we sat down, actually starting in March, to begin to plan for the 2014 health insurance renewal. Bad case scenario is that the data came in and it turned out that for the preceding 12-month period, our actual claims costs were 20% higher than the premiums that Medica was collecting. So they were paying out 20% more than what they were taking in premiums. And that's never a scenario you want to be in. And we knew that when Medica initially calculated its 2014 renewal, which is their rate increase, and they were saying that it should have been a 25.5% increase, but because long-standing customer, etc., a lot of it somewhat kind of advertising and puffery, but anyway, they came to us proposing a 16.8% increase. that was more than anybody on our side of the table wanted to bear. So we started to look at options of what could be done to try and bring that rate increase down. The consultant that's hired, paid for by the city, but actually works for the BLMC, so it works for both of us, was able to negotiate with Medica to decrease that percentage from 16.8 down to 15 if we would make some changes that would make the plan easier for them to administer. There were 3 features to the Minneapolis plan that's been in place all the way back to the days when Blue Cross was our provider that are really different from just about any other Medica client. And that has caused them a lot of time and money in setting up their software systems to manage that, but also in the filings, because in Minnesota, for any insurance plan to be able to be sold on the market, the insurance provider has to get approval of that from the Department of Commerce. So if they don't have a standardized off-the-shelf product, they have to go get special approval from the administrative agencies, and they have had to do that with ours. So that they offered us the ability to cut that down if we would, one, eliminate the fourth quarter carryover. Now the fourth quarter carryover has to do with how the deductible is tracked. It was a nice benefit in that if you had an illness, let's say you went in the hospital on December 28th, maybe it was for a heart attack or something, and you were there until January 5th, the fourth quarter carryover would allow you to have whatever the costs of that treatment spill over into the next year. So it counted toward your deductible for 2013 and toward the first quarter of 2014. Very difficult to track, and that was one of the things that Medica said they wanted to eliminate that and just go to a hard and fast cutoff on December 31st. The second thing was to change our prescription supply. For as long as I can remember, and I've been working for cops and the firefighters in Minneapolis for almost 25 years, the prescription benefit has been for a 34-day supply. These are for maintenance pills now, birth control pills, blood pressure pills, other types of things that people take for kind of chronic conditions that need to be constantly monitored. Nobody else has a 34-day supply. So Medica wanted to put us on 31, which again is standard. Now we realize that there's an impact on that, obviously, because if you get 3 less pills every time you fill, that's 1 more fill you're going to have to do every month. But again, I'll talk about the analysis on this in a minute. The last one is to eliminate the 100% coverage option for people who choose to have preventative care, which is basically your annual physical, or for women it includes a mammogram, that type of stuff, to go that out of network. And the reality is that no one does that. Okay, so that got us down to 15%, which is still a significant jump in rates. So we pushed Medica to find other options or other things that we could do to try and reduce the premiums further. And basically they came back and said that if we were willing to increase our deductible and out-of-pocket maximum, they would reduce our increase all the way down to 3.4%. Now that was a huge amount of money that we were anticipating saving here. Just put it into round terms. The city spends the total cost of premium. Now I'm not talking about what chunk is shared and paid by employees versus the city as employer. But just the total premium for the city of Minneapolis is roughly $50 million a year. So by saving 12% of 50 million is about $6 million bucks. So that is a very significant amount to be saved, and so that's one of the reasons why we had to take a look at this option. In addition to those actual changes to the plan, there were other things relating to health insurance generally that are always pretty much on the table. One of them is the VIVA. What do we do with the VIVA? Do we keep the contribution the same? Do we tweak it? What are the terms and conditions of that? There was also an issue raised with regard to retiree eligibility. A very limited issue that the city brought up, and it has to do with the ability of people who retire to leave the plan and then come back to the plan maybe a year or two or even 10 years later. Another issue that was brought up was the whole cost of family coverage. The family benefit in Minneapolis has been something that on the BLMC we have intentionally really driven to try and keep affordable and to be a very valuable benefit. Yeah.
You talk about that retiree eligible issue, well, what did they decide? Before you told me you got a year to make it, it's gonna come back and forth, right?
Well, as it stands right now, for people who are, I'll jump ahead, and when I get to it, I'll just skip over it, seeing as I asked the question. Right now, the current system is that when somebody retires, you are eligible to continue to participate in the city health plan. If you choose not to, or if you're in it for a year or two and then opt out, maybe you go on a spouse's plan, maybe you find something on the open market that's cheaper and you decide to go do that, you can. If down the road you decide you want to come back on the city plan, you're allowed to do that at the next open enrollment.
For how long?
For forever.
Oh, I didn't know.
Okay. What the change would do is for people who retire after 12/31 of this year, that benefit is, the ability to leave and come back is gone. People would still be eligible to remain on the city's plan, okay? But if you leave the plan, or if you opt out of it at the time of your retirement, you're not eligible to return. And I can tell you in a little bit when we get to it, why that's really not as big a factor as it used to be, and why the change was reasonable. The other issue is the wellness program. We take a look at that every year too to see what the requirements are going to be, what the options are that people are going to have to meet those requirements. In terms of both the qualifying threshold and then also who should participate. Traditionally, it has always been just the employee that's participated. Even if you have family coverage, no one else from the family has had to do it. So those were all of the issues that were on the table. As you can see, there was quite a lot of them there. And we worked through these collectively, as I said. And so I'm going to go through now and just explain what the final product of all of this was. And then I'll get into the explanation on a point-by-point basis as to why it made sense. And you can't really cherry pick and say, well, we like this and we don't like that, because this whole thing was, negotiated and derived collectively. So it's all kind of part of what makes the stew. So the first thing was, what do we do with premiums? And the good news on premiums is with the changes to the plan itself, the premiums are basically stable. For people that are in the elect or essential networks, they will see what they pay for premium per month actually go down next year relative to what they're paying this year. Not by a lot, but by a little. The people that are in the choice plan will see a slight increase. And again, not a lot, just a little. I think the increase for single coverage is about $6 a month, and for family coverage it's $13 or $14. We do have increases to the deductible and out-of-pocket maximum. Presently, the deductible for single is $1,000. That will go up to $2,000. The deductible for family is $2,000. That will go up to $4,000. The out-of-pocket maxes are also going up by $1,000 for single and $2,000 for family. We did accept the change to the prescription supply and the elimination of the fourth quarter carryover, which means that the deductible and the out-of-pocket max will reset on January 1st of every year. It's kind of a hard and fast deadline. Where you draw that line, though, really doesn't make a difference, because now you could say, well, it's not fair, yeah, we had this benefit before, but somebody who got sick on September 28th and that carried in over into October could have the same thing, because currently September 30th is the deadline. So you got to draw the line somewhere. Other changes. We did eliminate the out-of-network option for your preventative care. And we did eliminate double coverage for spouses. That's where you have both spouses work for the city of Minneapolis. In the past, ever since we went to this plan set back in 2004, with Aviva, there have been a few people who have taken advantage of, and I don't mean that in a bad way, but they've exercised the option to both take either family coverage. We've got some people that both have family coverage. We've also got some people that take family coverage for one spouse and the other one still maintains single. There's a significant benefit to that, not only in terms of getting the additional VEBA contribution, but also you get double coverage. And in Minnesota, we have what's called continuity of coverage laws that require, when you're covered by two different plans, for the secondary plan to actually pick up certain expenses that may not be covered by the first plan. So there were a lot of people that were in this situation that were essentially getting their health care for free. That was really never the intention when we set this whole thing up, and when the costs of providing those benefits, especially for family coverage, became significant, we had to look at some things that we could do to try and curtail it. The reality is because our family coverage is such a good benefit, the city has seen, just over the last 5 years, almost 200 people move from single coverage to family coverage. And that's fine, that's everybody's right to do during open enrollment. The city, however, is legitimately concerned about that trend because of the fact that every time somebody does that, between the increased premium that the city pays and the increased VEBA that the city pays, it's about $14,000 per person for anyone to make that jump. The city brought this up as an issue, and this was kind of the least common denominator that we could agree on without kind of starting to gut some of the family benefits, which we certainly did not want to do. I already talked about the no reentry for retirees. That will take effect for people who retire after 12/31 of this year. Now, as you can tell, these sound like a whole bunch of kind of takeaways or concessions. Yes, that's true. We did that to get the premium down. But to offset the cost, because remember back to the goals that we talked about in the beginning, we talked about trying to maintain a safety net for people. So one of the things that we did, because we know that the additional out-of-pocket costs are going to hit somebody, we were able to get the city to agree to create an additional VEBA contribution that people can earn as part of the wellness program. So if you go above and beyond the minimum requirements to get the lower premium, you can qualify for $200 additional to be put into your VEBA. We also got this, and to me personally, this was the most instrumental piece that made the increase in the deductible doable. I can't use the name of the company because the city's in the process of doing an RFP for it right now, and the city attorney's office has kind of warned us that we can't, talk about it, so it looks like we're skewing the deal. But there's a company out there, companies actually, that have created an ability for people to finally get some idea of what the cost of the care that they're getting is before they have to purchase it. For years I've been complaining about this when Medica and some of the other providers come and talk to us about market-based insurance, and I tell them, don't even talk to me about a market, because any other commodity in the whole world that I know of, there's a list and a price attached to it. And until you give me a price tag for stuff, I don't want to hear about your market. Well, this isn't quite that much of transparency, but at least a step in the right direction. This company, what it does, it's in the business of taking actual claims data from Minneapolis employees and their dependents that are covered by the plan. And those of you who look at your EOB's explanation of benefits when they come, you'll see the actual cost that's charged to the plan, because there's an amount there, and then there's the negotiated provider discount, and then there's something that either you or the plan pay. That's the cost of service for that provider. They've got a huge software program that kind of amalgamates all of this stuff and develops a list by provider of the actual cost that they charge by plan, because depending if you're in Electra, Essential, or Choice, the cost could be different because of the different in the negotiated price reductions for the providers. But they've aggregated all of this data. So for certain standardized procedures like an appendectomy or a knee replacement or a colonoscopy or a wide variety of things, and for prescription drugs, you can go onto this website. The city's going to pay for a membership for every employee. So you can log on, you can look up, and it will actually categorize all all providers in our networks into 3 categories. Green dot, which is the lowest cost, yellow dot, which is medium, and red dot, which is the highest. It's still your choice to go wherever you want to go, but at least if you're spending your own money in your VIBA, or if you're just want to make sure that you're going to a low-cost provider for the incentive, you can do that. Because that's the other piece of this program. Not only do they give you pricing information, but every time you go to a green dot provider for a service, they will, the company will rebate you with a cash rebate between $25 and $100, depending on the cost of the service. Obviously, lower cost is going to be closer to 25. A higher cost procedure, like some sort of a surgery or something, will be closer to $100. So that's another additional benefit to try and bridge this gap, okay, between the increased out-of-pocket risk that we're taking on here. And the final thing is, doesn't relate directly to health insurance, because it's actually death insurance. I've often wondered why we call it life insurance, because it only pays if you die. But for years, the city's life insurance benefit has only been $10,000. They will be increasing that next year to $50,000. So for any of you who are purchasing additional insurance now, you'll still continue to have the option to do that. But let's say you purchase $100,000, now you'll only need to purchase that increment from 50 to 100 instead of from 10 to 100, okay? So that's a significant benefit as well. Okay, now, the analysis behind these changes. On the fourth quarter carryover, this provision was very nice, but the reality was it was a rarely used benefit. And it was a significant administrative burden to Medica to do. The bottom line is that this whole package of changes really has the biggest impact on the high-end users. And this will not impact them at all, because they're going to hit their out-of-pocket maximum or their deductible far earlier in the year than shifting this deadline for the cutoff. So it's really not going to have any impact on those folks at all. So that was kind of an easy decision to make. The prescription drug supply thing, again, this was kind of more of an irritant. But in the end, we decided that it made sense to do for these facts. Number one, it only affects the maintenance drugs, okay? So if you have some situation and the doctor prescribes, say the kid has an ear infection or something and you go get amoxicillin or whatever, that's just going to be a one-time, 10-day supply or whatever it is. That's not going to be affected by this, obviously. This is going to affect those maintenance drugs. And the reality is, it probably will have a minimum cost, because 80% of all the prescriptions that our members fill are for generics. And under our plan, the generic cost is only $10. So even if you have to get one extra fill a year, because you're getting 3 less pills per, you used to be able to get by on 11 fills for the whole year. Now it's going to take you 12. You're probably looking at about a $10 increase for that. The preventative services, we actually tracked the records on this, and there was no record of anybody going outside their network for their annual physical. And quite frankly, it's hard to imagine why anyone would do that. Okay, the double coverage thing. There were about 160 people working for the city, so basically 80 couples that are going to be affected by this. And as I said before, it was kind of an unintended benefit that we just couldn't afford anymore. Everybody will still continue to have coverage. They will remain covered, but they're not going to be able to double up and get 2 VIBAs and 2 family coverages and whatnot. They can each have a single if there's no kids that they need to cover. But if one spouse takes family coverage, the other spouse cannot get any coverage. I have made an inquiry as to whether they will allow the spouses to agree to split their VIBA contribution, because again, that has a savings aspect to it. It won't increase the aggregate amount of the family VIBA, but I do think it would be fair to allow them, if they want to split a 50-50 or 60-40 or however they want to do it. So I haven't heard back from the city of whether that's even permissible, but at least we're asking about it. The re-entry option, this is the only thing that you're going to hear me talk about tonight unless there are questions, but it really doesn't affect our plan a whole lot on the Affordable Care Act. as you probably know, one of the provisions of the Affordable Care Act is that plans can no longer terminate coverage because you get sick, nor can they deny you coverage because of a pre-existing condition. That was the very reason that we had this re-entry provision in our plan, because what we found was retirees could find cheaper insurance for themselves on the open market, but if they did that, they took the risk of getting sick and then having the provider cancel their insurance. The safety valve was to allow them to jump back into the city plan. We don't need to do that anymore because that's prohibited. So they will be able to be just fine, and probably the retirees will actually be better off finding coverage on their own than even staying in the city plan. We'll know more in a few days. I think it's actually next week when the first exchange information hits us. But all of the initial reports are that, and this isn't, again, this is not an ad for Obamacare, I'm just telling you what I've read in the paper, that Minnesota's rates are actually going to be among the lowest in the country. So that's a benefit to retirees, because not only are they going to get low rates, but because of the way that the thing is structured, they'll probably also qualify for some federal subsidies to help them on their premiums.
Just a question I was asked today, Jim, sorry to interrupt, but just to say, can a retiree, even when we go, if we go self-insured, do you always foresee a wellness portion of it as far as a reduced rate? And if so, can the retiree take whatever wellness quiz or online scenario they'd have to get the reduced premium? I was asked that today.
Yes.
Okay.
First of all, just a couple things on this change, not directly to your question, but then I'll get to the question too. Remember, this change only affects people who retire after 12/31. So people who are already retired will continue to be able to jump back into the plan every open enrollment if they need to, okay? So that's the first thing. The other thing is that the retirees currently are eligible to get the reduced premium if they do the wellness, just like everybody else. And that's one of the reasons that we went to a premium-based wellness incentive, so that the retirees did have an incentive to participate. Other places, like St. Paul, where I also sit on their labor management committee, their incentive is additional money in the VEBA. Well, you can't give VEBA money to somebody after they're no longer an employee. So there's no incentive for their retirees to do any of this stuff. And the reality is they're the ones that really need to do it, because the retirees cost 3 times more per person than active employees. Now, that's just a function of age. I personally think it's also a function of having the time to go to the doctor a lot more, but it's mostly age. So no, this change will have no impact on people already retired. It will only affect future retirees, and like I said, because of the protections in the Affordable Care Act, people shouldn't really need to be bouncing back and forth. Okay, the changes to the deductible and the out-of-pocket max. These are kind of this is the biggest ticket item, so I'm going to spend the most time on it. Again, currently the deductible is $1,000 for single, $2,000 for family. The out-of-pocket max for single is $2,000. Now, what this means is, if you have, say, $1,000 of claim costs, you will pay that first $1,000 out of your own pocket. The out-of-pocket max is the maximum amount that you can pay in any given year. Once you've hit your deductible, the plan pays 80% of the costs, except for prescription drugs, because that's a fixed amount. But 80% of the amount, and you pay $20, which means to get to your out-of-pocket max of $2,000, you have to have $6,000 in claims, right? You pay the first $1,000 yourself, and then 20% of $5,000 is another $1,000. That gets you to $2,000. All right. For family coverage, it takes aggregate family claims of $12,000 to hit that max. The new deductible is going to be $2,000 and $4,000, as I said, and the out-of-pocket max is going to $3,000, which means that the threshold for maxing out now is going to be claims of $8,000, and for family, $18,000. Now, the relevance really of putting this up there is to look at how many people would be affected by this. Now, there's always the risk that it can happen to anybody, but The reality is it's actually going to affect very few people. This slide, the purpose of this is to just show you the impact of the difference between the 15% and the 3.4% on premium. Now don't get confused, this is total premium, so we're not into splitting who pays what yet. But as you can see, just pick one line. Let's just take choice W, which stands for wellness. So this is somebody in choice who's done the wellness. The single coverage cost, total premium, would have been $639